This is Dr. Jonathan Straus, and I am here to present on the management of the axilla in early breast cancer. It is a fantastically interesting topic for which we have great new data. So I'm really happy to be here and to share it with such an excellent conference. I thank the organizers again for my invitation. And let's jump in. I'm going to be talking about both data that covers the role of the surgeon in left and also the radiation oncologist. And so let's start just by very quickly mentioning the sentinel node biopsy. And so, we had implemented the sentinel node biopsy before we had randomized evidence. But having said that, we do have great randomized evidence, NSABP B32 being one great example. It enrolled 5,600 women with clinically node-negative breast cancer. And they were randomized either to get a sentinel node biopsy and a completion axillary dissection if positive, a sentinel node biopsy and a completion axillary dissection, or a sentinel node biopsy and a completion only if they were node positive. And what we saw was absolutely no difference in overall survival, in disease-free survival, in the number of regional recurrences. It was very clear that in women with clinically node-negative disease, who then had pathologic node-negative disease, that a sentinel node biopsy was just as good as an axillary dissection with clearly less toxicity. And so much more recently, we've come to this question, which is, all right, but what if the sentinel node biopsy is positive? What then? And so the first question, I think, is, should we do more surgery if a sentinel node biopsy is positive? I'll start with Ibcsg Z11. This is a nice trial. It closed early due to slow accrual. It did not reach its accrual goal of 2,000 women, but it had almost 900 women. They had T1 to T2 disease that was clinically node negative, but then had one or two positive sentinel nodes pathologically. Everyone underwent breast conserving surgery and sentinel node biopsy. Everyone was supposed to receive radiotherapy to the whole breast in the supine position. No one was supposed to get regional nodal irradiation. And they were randomized, and I would say almost all received systemic therapy. They were randomized between observation or a completion axillary dissection of levels 1 and 2, which I'll just say schematically is essentially here. And what did we find? In the half of women who underwent the completion axillary dissection, 27% had at least one additional positive axillary node. So the sentinel node, so for women who had a positive sentinel node, the sentinel node removed all their disease 3/4 of the time, but the other quarter there was residual disease in those in lymph nodes that could be dissected in the axillary dissection. Having said that, whether or not they got that completion dissection, the rate of regional recurrence was less than 1% and not different between the two arms. On the other hand, as we would expect, a completion dissection, and the completion dissection, I should say, was associated with no benefit in regional recurrence and disease-free survival and overall survival. It was associated, as we'd expect, with its known toxicities: lymphedema of the upper extremity, seromas, paresthesias, wound infection. An axillary node dissection brought no benefit of any kind, only toxicity. How could this be? I just like to say, how could it be that in 1/4 of these women, we could safely leave in low volume nodal disease and not have regional nodal recurrences? So the first question, I think, is, well, does the radiation help? Does that contribute to axillary control? And so here I want to mention 4 trials in this little table that randomized women at low risk with negative nodes and at low risk breast cancers. They randomized between whole breast radiation or nothing. And what we see is in the women who got whole breast radiation in every trial, we see, whether it's CALGB 9343, the trial in women over 70, Prime 2, a low risk trial in women over 65, and NCIC, which was mostly in women over 50, the Abcsg 8A trial, the Austrian trial, In every one of these trials, we saw fewer axillary recurrences in women who got whole breast radiation. Why is that? Well, remember, in the supine position, whole breast radiation tends to catch a lot of level 1 of the axilla. And this is where a lot of these lymph nodes are. And so as a result, it is clear that the radiotherapy received by most of these women, the trial mandated radiotherapy to the whole breast in the supine position, catches the low axilla and clearly contributes to the sterilization of low volume disease. Does chemotherapy contribute to control of low volume disease? It sure does. If we look at the rates of path-CR, pathologic complete response, in lymph nodes in women with known positive disease, it varies based on biologic subtype from all the way to, let's say, 5 to 10% in women with luminal A ER positive disease to maybe 70% in women with HER2, ER negative, HER2 positive disease. So it's clear that chemotherapy contributes somewhat to axillary control. What about endocrine therapy? I think that's also a contributor as well. I would say that the rates of pathologic CR are not high enough in chemotherapy to maybe rely on chemo alone, but it clearly contributes along with radiotherapy that catches that low axilla. So do we have other data that validate this? Sure, we have 2 other trials. We have the Ibcsg 2301 trial. This essentially recapitulated the Z11 trial, but in women with microscopic nodal disease. So these were women with T1 to T2 clinically node-negative breast cancer. They had a micrometastasis, 0.2 to 2 millimeters on the Sentinel node. The vast majority got breast conservation and whole breast radiation, and they were randomized to an axillary dissection or not, knowing that they were getting whole breast radiation covering a portion of that axilla. And what we saw was basically the same. There was a 13% chance of an additional positive axillary node in the dissection arm, lower than in Z11 because these women had lower volume disease in their sentinel nodes. Their 5-year rate of regional recurrence was extremely low in both arms, less than 1% and not different. A completion axillary dissection brought no oncologic benefits, only side effects. And we have the Eortc Amaros trial. This looked at 4,800 women with T1 to T2 breast cancer who were clinically node negative. They had a sentinel node biopsy. Those who were sentinel node positive were randomized between a completion dissection or radiotherapy. The radiotherapy, so this completion dissection would tend to cover levels 1 and 2. The radiotherapy also covered level 3 and the supraclavicular fossa, level 4. Only 10% of women in both arms received IM nodal radiation. This was not part of the randomization. So it was axillary dissection versus radiotherapy to the axilla and supraclavicular fossa. What did we see? Of the women who underwent axillary dissection, 33%, so a third, had an additional positive node at axillary dissection, and yet the 5-year axillary recurrence rates were very low and not different between the 2 arms. So in this case, axillary radiotherapy was equally effective as an axillary dissection. However, it was less morbid. The rate of lymphedema was twice as high in the axillary dissection arm as compared to the sentinel node biopsy and axillary radiotherapy arm. And we had 10-year follow-up of the Amaros trial that have been presented that maintain the exact same finding. No different in axillary recurrence, no different in any of these oncologic endpoints, only a difference in lymphedema rates. So what's really nice about those 3 surgical trials is they all tell us the same thing. For women with clinically node-negative disease who have 1 or 2 positive sentinel nodes and who are planning to get radiotherapy, there is no difference. There's no benefit for an axillary dissection. It brings only side effects clearly validated in 3 separate trials. What about the role of regional nodal irradiation? I like to think of us radiation oncologists, we're kind of the bakers. What about us? What do we bring? Well, remember first that radiation to the breast brings with it not only a significant reduction in local regional recurrence, but a big survival advantage, especially in women with node-positive breast cancer. Is there an incremental additional benefit to adding radiation to the lymph nodes in addition to the breast? Well, we've got a few trials that directly asked that question, cutting to the chase, the answer is yes, there is additional benefit for regional nodal irradiation. We can look at the Canadian MA20 trial. This trial enrolled 1,800 women, the vast majority of whom, 85%, had 1 to 3 positive nodes. I think of this as a 1 to 3 positive node trial. Everyone underwent lumpectomy and axillary dissection. Almost everyone got systemic therapy. Everyone got radiotherapy to the breast to 50 gray. And the randomization was plus or minus regional nodal radiation. And it was essentially the undissected axillary apex and supraclavicular fossa and internal mammary chain, both or neither. I will say that about 1/3 of the women in this trial did get radiation to the dissected axilla if either they had 4 or more nodes positive, that was only 5% of the women, or more often if they had fewer than 10 nodes dissected. What did we find? We found that the addition of regional nodal irradiation reduced local regional recurrence by 3%. It improved distant disease-free survival by 4%. It improved disease-free survival by 5%. Its numerical benefit in overall survival was not statistically significant. Of note, the addition of regional nodal radiation did add a little bit to the pneumonitis risk and did increase the risk of lymphedema. My own view, it's probably mostly in these women where we irradiated the dissected axilla where we were really increasing lymphedema risk. And we see here in these graphs just these small but very clear oncologic benefits from regional nodal irradiation. The trick was when we looked on subset analysis, trying to find out which subset of women derived the most benefit from regional nodal irradiation. And here we look at a forest plot. What we find is everything's to the left of one. Basically, every subset of women benefit. There was this hint that maybe most of the benefit was in women with ER negative disease. We'll see in a minute that was not validated on its sister trial. So the sister trial is Eortc 22922. This is a European trial. It was twice as large. It enrolled 4,000 women. Almost half of these women had central to medial, but node negative tumors. So this part of the breast, but node negative. The other half of women had positive nodes, usually 1 to 3 positive nodes. Again, these women were randomized to most women got a lumpectomy, some a mastectomy. Everyone got an axillary dissection. Almost everyone got systemic therapy. And women got radiation to the breast or to the chest wall, and everyone was randomized plus or minus radiation to the draining lymphatics, either to the undissected axillary apex and supraclavicular fossa and the internal mammary chain, or neither. And again, what we saw were oncologic benefits that came from regional nodal irradiation, an improvement in disease-free survival, metastasis-free survival, and a reduction in breast cancer mortality. You can see that the overall survival advantage just missed statistical significance. The benefit, at least by hazard ratio, was the same regardless of the number of lymph nodes involved. And in this trial, there was not a statistical difference in lymphedema risk. And again, it may be because only 8% of women in this trial got radiotherapy to that dissected axilla. And again, what we see on forest plot is that we cannot identify a subset of women who derive most of the benefit and then subsets of women who don't benefit. It sure looks like everyone gets a small but reproducible, statistically significant benefit from regional nodal irradiation. And again, if we look in the appendix, what we see is that women who got endocrine therapy, so one imagines these are the women with ER positive disease, they seem to derive more benefit than those who got chemo alone. Essentially, the exact opposite of what we saw in MA20. So it doesn't look like estrogen receptor status should be driving this, at least not on its own. More to follow. We have a 15-year update. Again, we continue to see now a 4% benefit in breast cancer mortality. Again, we see a numerical benefit in overall survival that doesn't quite make statistical significance. There was no difference between the arms in radiation-induced malignancy risk or any second malignancy in contralateral breast cancers and cardiovascular deaths. What about future trials? We have a series of trials on the horizon that are asking similar questions, but some are asking questions like, do we need to do any axillary treatment? Or is no axillary treatment, no radiotherapy or surgery going to be sufficient for these patients and leave it to systemic therapy alone. I think these are going to be great trials to see them mature. By the way, while we're treating the regional nodes, do we need to treat the internal mammary chain? Or is all the benefit coming from treating these nodes up here? The best data I think we have for this come from a very cool Danish study. What the Danes did was they had decided that they wanted to treat the internal mammary chain, but they were concerned about heart dose. So they decided to treat the internal mammary nodes for all women with right-sided breast cancer and positive axillary nodes, and for no women with left-sided breast cancer and positive axillary nodes. And as a result, although this was not randomized, there really was no selection bias. What do we see? We see that women with right-sided breast cancer had a survival advantage as compared to women with left-sided breast cancer, strongly suggesting that the encompassing of the internal mammary chain provided a small but notable survival advantage. Also of note, there was no difference in breast cancer death between people who received radiotherapy and those who received no radiotherapy, between right and left side. Didn't look like we were increasing death from radiotherapy. It looked only like we were reducing the risk of a breast cancer death when we encompass the internal mammary chain. I think it matters. So we believe in regional nodal irradiation, but for whom? This is Oprah Winfrey. You might know her from America, and she likes to give gifts where everyone gets a gift. You get a car, and you get a car, and you get a car. The question for us is, do we need to give everybody regional nodal irradiation, or can we just target it to some women? Well, we do have an unplanned exploratory analysis from the MA20 trial that's very interesting. It looked like when we looked at women with, I'll call luminal A-like breast cancer, positive for estrogen and progesterone receptors, negative for HER2, and grades 1 or 2, so low grade, strongly ER positive, there appeared to be no benefit for regional nodal irradiation. By contrast, women with luminal B-like breast cancer, those who were estrogen or progesterone receptor positive, but also either HER2 positive or high grade, again, this is a rough surrogate for luminal B status, there seemed to be a large benefit for regional nodal irradiation, and the same for women who were ER negative, whether or not they were HER2 positive. Maybe women with luminal A-like breast cancers could forego regional nodal irradiation. Maybe. And in fact, we have some similar data suggesting that the risk of local regional recurrence is much higher in women with high oncotypes than in those with intermediate or low oncotypes. The oncotype recurrence score, the 21 gene recurrence score, correlating reasonably well with this luminal A versus luminal B status. Well, to really ask this question, the Canadian group is moving forward with the MA39 trial. We're in accruing women to this study as well. This looks at women with essentially 1 or 2 positive sentinel nodes who are estrogen positive and whose 21 gene recurrence score is less than 18, and randomizing them if they're getting whole breast radiation. So if they had breast conservation, randomizing them plus or minus regional nodal irradiation, trying to figure out if we can safely omit regional nodal irradiation for women with relatively low volume disease that has a low risk oncotype, essentially women who are in the luminal A-ish good response to endocrine therapy. There's also some very early data out of France suggesting that maybe the benefit for regional nodal irradiation is concentrated in women who have circulating disseminated tumor cells and not in women who don't. So perhaps this is a marker for some residual disease in the nodal basin, some surrogate marker for that, and therefore a benefit of regional nodal irradiation. More data are needed. But I think it's clear to say this: when we're looking at women with clinically node-negative breast cancer who have 1 to 2 positive nodes, assuming we're going to do radiotherapy, we should not do a completion dissection. We should do irradiation to their undissected lymph nodes. We should probably encompass the internal mammary chain. And future research will tell us whether we can safely find groups of women to omit radiotherapy, but for now, I think it's pretty standard. So I'm going to pause and see if the audience has questions.
Thank you very much, Dr. Straus. Do anybody have any questions? Can I have a question, please? In the technique of irradiating the internal mammary lymph node, what you usually do, you encompass the internal mammary in the medial tangential, or you give mixed beam separate field for the internal mammary field?
That is an excellent question. And I do actually think that the encompassing the internal mammary chain for me is based on two thoughts. How much benefit are we getting? And can we do it really safely, especially with regard to heart dose? And I think those two, we really have to kind of look at both of those. So we like to treat women at deep inspiration breath hold. So we do this for both left and right-sided breast cancers, although the benefit is larger for women with left-sided breast cancer. For those of you who are not doing it, I would point to the UK Heart Spare trial. There are very cost-effective ways to do this. So we have everyone at deep inspiration breath hold. The heart has moved posterior, inferior with relation to the breast. Then we will typically do a partially wide tangent. So a tangent that's wide to encompass the first three intercostal spaces, and then the tangent narrows. And that's our go-to. I think we get the lowest heart dose from that. On the left side, we will still tend to keep our mean heart dose under 1.5 gray, using deep inspiration breath hold, a partially wide tangent technique, and if we need to, a small cardiac block inferiorly, and we can patch in little electrons or something to cover the tissue that we're missing, but always excluding the entire heart, the entire cardiac shadow from the direct radiation beam. So that's what we tend to do, deep inspiration breath hold and partially wide tangent. Now, do we ever modify that? Sure. Rare cases with different anatomy, we may patch in electrons or other things to catch the internal mammary chain, but usually partially wide.
Thank you very much. A very comprehensive answer. Any questions? I'd like to know your own opinion. Do you think this kind of trials will change the practice by omitting axillary dissection in the future for a category of a subcategory of patients, as we hope?
Oh, yes. I think the axillary dissection is going to get fewer, is becoming from a common surgery to really closer to a niche surgery. And I think we're going to see now, we're looking to see, can we omit it even when there's residual nodal disease after neoadjuvant chemotherapy? I think next question will be, can we omit it for clinically node positive disease, or can we omit it when there's more than 2 positive sentinel nodes? I think it's not going to disappear, but I think we're going to see it becoming more and more niche. And I'll say at my institution, our breast surgery fellows who are training specifically in breast surgery, they used to get tons of axillary dissections. Now they get very few. And so I do really think all of a sudden we have to look at how much training they're getting in that surgery. I do really think we're going to see fewer and fewer axillary dissections. And as a result, I really hope to see that upper extremity lymphedema and some of this arm dysfunction will really be a thing of the past.
So the other side of the story, what kind of patient you think will benefit from radical and local regional nodal irradiation?
Yeah, that is an excellent question, because right now what our trials told us was regional nodal radiation gives a small benefit, but we kind of have to treat everyone because we can't pick out who doesn't need it. And I think there are two promising avenues to help refine that selection. And one is using like a 21 gene risk score like the Oncotype. And again, we're accruing women to the BMA39 trial to try that approach. And I also think that either circulating tumor cell or circulating tumor DNA may actually be a marker for some residual regional disease. At least there's very early data for that. So I would say there are two approaches that I hope will give us data. But for right now, for women with macroscopic nodal disease, I'm still routinely doing regional nodal irradiation because we haven't been able to figure out a better way to select the women who benefit from those who don't.
Thank you very much, Dr. Straus. We really enjoyed your and benefited from your very nice talk. Now we move to the other speaker. Thank you.